Hello and welcome everyone to today's webinar titled Braiding Funding Streams to Deliver Integrated Care for Medi-Cal Members under CalAIM. My name is Twin Tran, a Senior Program Officer with the Center for Healthcare Strategies, and I will be your moderator for today's session. This webinar is made possible with support from the California Healthcare Foundation. Next slide, please. So, a few housekeeping details before we begin. Please use the Q&A function to submit your questions. Thank you to our amazing CHCS communications and program colleagues for monitoring our chat and for their technical support. Next slide, please. So here's what we'll cover during our webinar. First, we'll provide an overview of braiding and why it can be an integral component to organizations looking to enhance and/or expand their services. Then we'll road trip to Humboldt County and Alameda County to learn how our CADA House Partnership and the Community Health Center Network are braiding in practice. And finally, we'll have an opportunity for a Q&A with our panelists before wrapping up. Next slide, please. So a note on who we are at the Center for Healthcare Strategies. If this is the first time you're joining us, a warm welcome, and what a fantastic webinar for you to get to know us better. CHCS is a policy design and implementation partner dedicated to strengthening the U.S. healthcare system to support high quality and equitable care, particularly for people served by Medicaid. To achieve our mission, we partner with state and federal agencies, health plans, providers, community-based organizations, and community members to address obstacles that stand in the way of good health and well-being. This includes barriers like poverty, complex health and social needs, and systemic racism. Next slide, please. Okay. Now that our housekeeping is out of the way, I am so delighted to introduce our presenters for today's webinar. We have Melora Simon, Associate Director of Complex Care with the California Healthcare Foundation, Darlene Spohr, Executive Director of our CADA House Partnership, Virginia Beckman, Pathway CalAIM Director of our CADA House Partnership, Hallie Roth, Population Health and Quality Improvement Manager with the Community Health Center Network, and Kush Grewal, Medical Director, Community Health Center Network. And with that out of the way, Melora, I will pass the mic over to you for a few opening remarks.
Thanks so much, Twin. For those of you who don't know us, the California Healthcare Foundation is an independent nonprofit philanthropy that works to improve the healthcare system so that all Californians have the care they need. We focus especially on making sure the system works for Californians with low incomes and in communities who have traditionally faced the greatest barriers to care. As a result, not surprisingly, we're very focused on CalAIM and its potential to address inequities and advance the delivery of person-centered care. To that end, we've set up a resource center dedicated to CalAIM and have also recently launched a survey to better understand the experiences of those actively implementing these programs. If that applies to you, I hope you'll lend your voice and complete the survey. And I know that colleagues at CHCS are putting the links in the chat right now. Next slide. But on to the topic at hand. What is CalAIM? So launched in January 2022, CalAIM is a multi-year care delivery and payment reform initiative that creates an opportunity to bring healthcare services and social services together for people with complex needs. It does other things as well, but those are really the elements that we're focusing on today. There are two major components to achieve those goals. One is called Enhanced Care Management, or ECM, and that's a high-touch care coordination program for people with the most complex needs. And the other is Community Supports, which are 14 pre-approved services that haven't historically been covered by Medicaid. So things like housing navigation, medically tailored meals, sobering centers, all of which can help address the social risk factors that we know drive health. So CalAIM has enabled social service organizations to tap into Medi-Cal funding to provide person-centered care. And at the same time, that's added complexity, as organizations may need to braid Medicaid funding with other funding streams or use multiple Medicaid funding sources together in order to achieve this goal of providing person-centered care. So I'm going to turn it back over to Twin to define what we mean by braiding and talk about some of the risks and opportunities that it brings before we hear from our road trip across the state. Thanks.
Awesome. Thank you, Melora. So what is braiding? Braiding involves combining funds from multiple sources to support a common goal while ensuring that each funding source maintains its specific program identity and can be tracked independently. The funds remain distinct and are only used for their specific purpose. When braiding is successful, as Melora had noted, organizations can fill gaps in services to provide more comprehensive care, serve more individuals, and build program sustainability. Next slide, please. As the braiding of Medicaid funding is relatively new for many service delivery organizations in California and across the country, bringing new opportunities, but also new challenges. One key challenge is supplantation, and it's defined as when an original ongoing funding stream is replaced with a new funding source to deliver the same service. Federal and state rules prohibit organizations braiding Medicaid funds to use Medicaid funds to replace their existing funds. However, organizations are encouraged to braid in Medicaid sources to supplement and or sequence services. So supplement and sequence really means using these new funds to increase the size, scope, and or quality of services being offered, or provide new services that are separate but sequential. So with that overview, let's learn more about how it looks in practice. Darlene and Virginia, I will hand it over to you.
Thank you very much for having us. It is my pleasure as Arcata House Partnership to be presenting the opportunities that we've been given over this last year and a half. For the first time in our history, and our organization's 32 years old, we now have an opportunity to bring in some supportive services that have been previously unfunded. And so I want to talk a little about our agency and about how this program, CalAIM, fits into us. And then Virginia has the specifics and the details because she's really the director over this program. Next slide, please. Arcata House Partnership is the largest homeless service provider in Humboldt County. Humboldt County is in the far north of California, not quite to Oregon. There's one county between us and Oregon, but that's how far up we are. We have 13 locations across the county, and 4 of those have 24/7 on-site coverage. We're the only agency here in Humboldt County that provides the full continuum of services for people who are homeless or at risk of becoming homeless. We provide outreach, connection and referral, shelters, rapid rehousing, permanent supportive housing programs and rapid rehousing programs, and food service. All of those together allow us to serve the person from the very first start when we can connect with them, and sometimes that might take a year or 2 on the street for them to trust us, all the way through permanent housing, and we are honored to be able to do that. We serve about 900 participants a year and provide housing for 121 housing units, which is pretty amazing for this part of California. Our funding sources are vast. We have most of our funding sources are grant funded, except CalAIM is our first billable funding source in that way. We get money from HUD, and get emergency solutions grant funds, housing and community development out of California, which is the way to manage HUD money in California, CalFresh, again, Path Cited, which is the grant that allowed us to start the whole CalAIM program. We have lots of partnerships. lots of local funders. We get funding from the county and the city, and our faith partners are really important to us as well. They actually 32 years ago, it was the faith partners that started Arcata House Partnership, and they continue to be big supporters. The program, the Pathway program is what we're calling our CalAIM program, provides enhanced care management, community support services, and community health worker services. Next slide, please. The way we do that here at Arcata House Partnership is through this three-pronged approach. We've always had housing and support for shelter and housing programs, and the supportive services, which is case management. So we've had that for a very long time. But there's been these gaps that people need in order to help them transition from being on the streets, being homeless, into being permanently housed, that we just haven't had other ways to support until now. The CalAIM program supplements services, and I want to be really clear here that we try really hard to make sure that we're not supplanting. And it's important for us because we get funding for some services, and that's what those grants and staff under those programs provide. And we get funding for services that CalAIM provides. And so next slide, please. When we're talking about braiding, this is where it gets really tricky and very specific for us. So our fiscal staff are trained to make sure that we are not billing things to programs or to funding sources that should get billed somewhere else. So we're very, very careful to separate job duties and assignments. When people fill out their timesheets, if they're working for one program and they're doing certain tasks for that program, that's where they get assigned to. For those of you who do fund accounting, you understand how difficult that is to make sure that we're not supplanting, because I never want to have the appearance that we're not managing our fund accounts very carefully. So that separation of job duties and assignments is really important. So for example, if HUD pays us to do case management for someone, those duties are really clear, and that staff person works as a case manager under that HUD program, and that's what they do. They don't provide services under ECM or other or community support work or other services. That is their job and that is their duty. Under Virginia's program, if people provide ECM or community support or housing transition services, that's what they do. They're not case managers. So in this little triangle, it's really important that all three teams work together to provide a holistic approach to the people that we serve, but they each do it in their own way and their own department. And we now have departments, which we didn't used to, so that we can keep them very separate and very clean. Next slide, please.
So I'll jump in here if I can with a couple of the things that we wanted to highlight. So Arcata House Partnership has been doing braided funding both at the kind of macro organizational level, like Darlene was talking about, braiding HUD money with CalAIM money with other grants and private foundations. And then within the CalAIM program, we're also micro braiding funding, and that the same staff are providing ECM and community support services. We've just had to, like, and one of the tricks of the trade with that is just meticulous documentation. So internally, we've created those documentation tools. We have a form, we call it a client monthly engagement tracker, where every engagement is tracked, the time, span that is tracked, and which service is offered by whom, so that we can keep that very clean and very distinct. We wanted to kind of mention a couple of the challenges that happen with this sort of adventure with this kind of different funding approach. And that for social services for community-based organizations like Arcata House, it's a complete culture shift from just grant funding and providing services that are funded through grants and now having services that are billable. So it's very, very specific to time spent and measurable in terms of points of care. So that's a very different approach. And also we had to kind of beef up the infrastructure at Arcata House to support this new venture. We had to look into electronic claims processing, and we had to learn how to do medical billing, which are things outside the general scope of services for social service organizations. We also,
Next slide, please.
and we also
And Virginia, keep
we also wanted to throw in there just a little commentary a little bit. I'm sure it'll come up more in discussion because when we were sent questions, this was something, a recurring theme that we saw. People were saying, like, is there advocacy being done at the state level to increase reimbursement rates for these kinds of services? And that is absolutely needed. That's a challenge in this work in that it's healthcare funding that's supporting community-based organizations' work. And there's a difference there in terms of the value our society puts on the work of small nonprofits in the community, right? Small nonprofits in the community are doing life-saving work. Housing is healthcare, and that's what Arcata House does. And we need to continue with those advocacy efforts at the state level to reimburse at a rate that is comparable to the value that we begin to put on that work. So that's our little soapbox to talk about that. So, okay, go ahead with Darlene.
No, Virginia, this is great. I think that the big thing that's really a challenge for us moving forward is until now, all of the staff at Arcata House Partnership assume that somebody else is going to go find the money and they're going to be able to do their work without restriction or time accountability. It's not accountability because we certainly do that, but without time restriction or time accountability. And this program is very different. And so over the next year, Virginia and I, working with our team and our team across all of Arcata House Partnership, is going to have to devise a way that staff think differently in this program, right? So our case managers come to work and they have a caseload of 30 and they do their job. And if they need to be with Mary Jane for an hour and a half today to help her with something, then that happens. Well, when we're billing for ECM or community support work, that's not exactly the way it happens. If we can bill for 30 minutes, they get 30 minutes of work. We have to think of things more on that medical side, not in medical service, but you know, when you go to the doctors, you get a 20-minute window, and that's how long your provider can see you. And so our staff in this program, we really have to help them realize that this is an enhancement to what we're already doing, that it's the third leg of what we're already doing, and it's not the whole thing. And so they don't have to spend an hour and a half with Mary Jane. They do their 30 minutes, their piece, then they hand it off to the case manager, who has more time to do those more in-depth, take care of those more in-depth needs with people. So that's a real culture shift, as Virginia started talking about. And what does that look like? And we don't have all the answers yet. So if somebody out there has the answers, send them on over, because that's our next big struggle. I think we have our fiscal in place. We have our payroll in place. We have our duties and responsibilities in place. But now that culture shift in the way that staff view their work is really going to be our next challenge over the year.
So far, in thinking of braiding funding, has this been successful for us? Well, thus far, we've managed to get to a point with our CalAIM team that it is self-sustaining by, a very tight squeeze. I'll add that piece of it. So we're really looking, like Darlene said, to think of a business model to help this grow and increase, the revenue that we're able to generate with this funding. And how can we be successful with this? Clear and consistent communication across the organization so that every department understands what role they play and understands what roles the other departments play, so that each team can work together and complement each other rather than duplicating services and muddying the waters of those different braiding funding sources. And with us, it was, I won't say completely easy, but it was fairly easy because the folks served by our Arcata House partnership are the people with the highest needs in our community. So it's not a hard sell to say that the folks served by our Arcata House partnership need supplemental services. Everybody served by our Arcata House partnership can benefit from another layer of support. So it's been easy for us to identify how we can make the supplement piece work for Arcata House rather than the supplanting danger zone of funding.
Thank you.
I think that's all we had.
Hey everyone, I'm Kush Graywall. I'm with the Community Health Center Network, and we're going to be presenting on our Transitions of Care program. So thank you for having us and thanks for being here. Could we go to the first slide, please, the intro and background? So basically, Community Health Center Network, it's a partnership of community health centers in Alameda County. And the health centers came together to kind of enhance and improve our ability to provide comprehensive quality health care that's respectful to our community's traditions and values. Definitely our health centers kind of grew organically in the communities that they were formed in, but with Medi-Cal and all the changes that come, it feels like every year, every month, they did need an organization to kind of come together and help us navigate these waters. So that's sort of the role of CHCN. We serve about 200,000 Medi-Cal members at 105 clinic locations across the East Bay. Our organization currently receives funding from 16 different grants, 11 different funders. So there is a lot of braiding that is sort of inherent to our work, and our organization is familiar with it and then the challenges of it. And we'll talk about it specifically in the context of transitions of care. Next slide, please. So these are the health centers we represent, all wonderful places, all, really important in our communities. And so just wanted to give a shout out to them. Next slide, please. So the Care Transitions Nursing Program has a bit of a history. So basically it comes from the knowledge that all evidence shows that re-engagement with primary care is the best way for a patient to not go back to the hospital and experience worsening health, decreased quality of life, all of these things. Like engagement with their primary home is absolutely essential for a patient to be healthy once they're discharged from the hospital. Initially, this was funded by a health system in Alameda County. They were interested in reducing admissions and readmissions from our member health centers. So they gave us funding through their community benefits to develop 4 nurse-led teams at 4 of our health centers to kind of provide medical case management for patients who'd been admitted to the hospital. The case management was going to consist of having patients receive a phone call from the health center that they're assigned to, saying, we saw that you were in the hospital. We'd like you to schedule a follow-up with your PCP. We're going to help you do that. Also, providing important discharge follow-up, like doing a medication reconciliation, which is often one of the most confusing parts of leaving the hospital for patients. They're going out with 8 different medications. What are these for, and how do I take them? And who do I talk to if I don't feel good on them? And then also providing social care referrals. If one of our nurses sees that the patient has been in the hospital 4 or 5 times for their diabetes, then maybe they need a referral to ECM. They need to get more intensive case management, and our nurses are sort of there to provide that follow-up. After the community benefits grant kind of sunset 2 years ago, we discussed the need to continue this program with our managed Medi-Cal plan. And so they agreed to provide funding, and it now supports all of our member health centers. And we obviously expanded our patient population, because now, instead of just serving patients who had gone to one specific hospital, it's all hospitals, wherever the patients went, all patients. And we're also, trying to expand our reach to include more CBO connections, so that patients can kind of receive more holistic care. Our primary goal is basically to prevent hospital admissions and readmissions through primary care engagement. We know that this is this has the best evidence for improving our patients' health, for keeping them out of the hospital and in the community as healthy as possible. Next slide, please. So as I mentioned, we receive most of our funding from Alameda Alliance for Health, which is our managed care plan. I think y'all must be familiar with like the new transitional care management requirements that have been rolled out as part of CalAIM. And so now the Alliance has asked us to provide transitional care services to all of our patients through CTRN. That is the goal of the program. Again, the primary focus is on making sure that our patients reconnect with their hospital. I think even like with the most health literate patients and like the most well-equipped clinics, patients often still have difficulty transitioning, either kind of remembering to make a follow-up, or knowing which specialist to call for follow-up. And again, medications is another big one. Did their pharmacy give them all the medications they need? Do they know how to take them? And with our patients who generally like are not as health literate, and our clinics don't have the same resources to do outreach, we want to provide the same level of care, and we want to make sure that we outreach when our patients aren't able to or may not know that they need to. The next slide, please. So the expansion of the program after we switched to our managed care plan, we identified that about 40% of our health center patients who are hospitalized also have a secondary diagnosis of a behavioral health condition. I think, it's known that patients who are in the hospital a lot for, let's say, diabetes control may not necessarily be there because they don't know how to take their insulin, or their condition is such that it cannot be controlled in an outpatient setting. It's patients experience a lot of anxiety and depression related to chronic health conditions, and all of those can affect their ability to self-manage and also know when they need to seek out care with a primary care provider, or when they need to see their specialists. Behavioral health affects our physical health. But based on, CTR and experience and experience from our providers, the patients who have behavioral health needs often have difficulty engaging with behavioral health once they're discharged from the hospital, either because of lack of access, a lack of knowledge of how to, or, maybe just too much of a focus on their medical needs and not necessarily addressing behavioral health needs that might affect their behavioral condition. So this was where we kind of identified a need to provide better behavioral health support through our CTRN program. And we partnered with Alameda County Behavioral Health to provide us some funding to support these patients. And I think Hallie will continue and talk about the program and how we changed. Thank you.
Next slide, please. Yeah, so after we had, excuse me, conducted that analysis, we decided to move forward with a behavioral health expansion through a partnership with Alameda County Behavioral Health, and that's where our braided efforts kind of came in for this program. So to expand the reach of the program and coordinate care for patients with identified behavioral health needs, we decided to supplement our existing program with more funding from the county to support a couple of things that the existing funding didn't exactly support. So we use some of the funding from ACBH to partially support our nurse salaries to expand medical case management for patients with an identified behavioral health need. We were also able to deepen our partnership with inpatient psychiatric facilities that we collaborate with pretty closely. And the funding also provided prepaid cell phones for unhoused patients, which has been really critical for us to support follow-up for patients who are really hard to reach once they are discharged from our partner facilities. The funding has also allowed us to support trainings for nursing staff on trauma-informed care. We had heard from a lot of our nurses that they didn't feel very equipped to manage follow-up for patients with behavioral health needs based on their own training. So this has been really helpful funding to support those trainings for them. And I think the overarching goal with the additional funding, the braided funding, is to further integrate our nursing staff with our behavioral health staff at the clinics. So the way that the program was set up initially, as Kush was talking about, it's mostly like a medical case management program, the care transitions nursing program, that is. And we have kind of explored what it might look like to collaborate a little more closely with the behavioral health folks at our clinics. And so we've been able to use the funding to support just more communication between the IBH folks and the nursing staff, warm handoffs, stronger referrals, and kind of joint case management for patients with behavioral health needs. Next slide, please. So this is kind of how our braiding works. So it's a bit of a visual that shows how we've defined our populations for mostly reporting, but also just understanding how each stakeholder views the program and the population of focus for them. So I guess starting on the right, for Alameda Alliance for Health, our population for them is Alliance members within our network who had inpatient discharges, needing mostly medical transitional care services. So of course, the program, the way it was created, is mostly a medical program for case management. And then Alameda County Behavioral Health, our secondary funder, is focused on all patients within our network who need transitional care, but have an identified behavioral health or substance use disorder need. And then the overlap between the populations, the middle of the Venn diagram, would be Alameda Alliance members who need transitional care, but who have that identified behavioral health or substance use disorder need. So the core difference is for our managed care plan, because they're reporting to the state on transitional care services, they're focused on our members through Alameda Alliance, but the county is focused on all patients. So it's been kind of a balancing act with the braiding to define our populations appropriately and make sure we're in alignment with each funder on the core group of patients that they're focused on for follow-up. Next slide, please. So these are just some strategies that we've come up with to manage our funding streams. I think it's a challenge for sure to braid. And I think some of this is still a work in progress, but it's been a really interesting exercise to be able to manage multiple funding streams to support one program. So we would say ensuring consistent check-ins with each funder to discuss data, reporting, program challenges, all of that is really critical. We meet with each funder monthly to talk about the program and ensure consistent alignment, make sure that we're meeting their needs, but also staying true to the program. Also developing a charter with each funder has been really helpful to ensure we're aligned on our KPIs or outcome measures. I will say each one looks very different. There's some overlap, but Alameda Alliance and Alameda County Behavioral Health both are individually looking at different things. And so that has been part of the work, is making sure that we're reporting on the metrics that matter for each funder as we meet with them. And then just defining your eligible population for reporting early and ensuring alignment with the funder. This is something that we continue to work through. Something Kush and I have talked a lot about with Alameda County Behavioral Health is how do we define a patient who has behavioral health needs? We mostly look at primary diagnosis, but there are times where patients are being discharged with primary medical diagnosis, but maybe have a secondary issue that's behavioral health related, like acute anxiety. And so we're working with our nurses to understand what follow-up might look like for those patients. How do we appropriately define behavioral health need? Because it's not something that we had historically done with Alameda Alliance for the program. So the behavioral health expansion has created some more questions for us to try to answer with population definition. Also, of course, staying on top of budget management has been really critical for us. And our overarching goal throughout the past year and into next year is standardizing our data and documentation to really ease the reporting burden. We're working really hard on this to make sure that the nursing staff that does follow-up can accurately document their follow-up and distinguish between an outreach call and a successful outreach, making sure that their referrals to behavioral health or social care are really defined, and it makes it a lot easier for our analytics team to pull that data and report on it to the funders. Next slide, please. So we'll just highlight a couple of successes and challenges. I know we only have a couple minutes. So for our braiding successes, our nursing staff have received a lot of psychoeducation with these funds from Alameda County. I know I mentioned that they expressed needing some of this if they were going to do more follow-up for patients with BH needs. So it's been great to partner with the county to offer some trainings on whole person care. How do you potentially broach sensitive conversations with patients with BH needs over the phone? That's been really successful. We've also steadily increased our referrals to behavioral health as we continue to focus on that care transitions behavioral health partnership at our clinics. We have deepened the relationship, I'd say, with our primary inpatient psychiatric facility we work with. And we've provided cell phones for unhoused patients to help with the PCP connection post-discharge. And our current 30-day PCP follow-up rate, so that's what percentage of discharges are receiving a primary care visit within 30 days. The rate for our program right now is about 58%, which is really strong. And we're really proud of all of the work that the nursing staff has done to support connecting patients to primary care. Next slide, please. So some of our challenges, this is what Kush and I talk about a lot with this program. I think overall capacity to manage discharge volume continues to pose a challenge for us. We chose to partially support existing salaries with the ACBH funds instead of hiring psych RNs. But maybe that is something we could explore moving forward. And I think a bigger question we've thought about is this program, this care transitions program, existed before the funding changed, before CalAIM. And so we're deciding, how much do we mold the program to move with the times versus keep it status quo the way it was intended and potentially supplement, with other funding sources. So that's where this question of, do we hire more psych RNs versus keep our existing nurses and supplement their salary? That's the questions that we're asking ourselves now. Data wrangling for reporting is definitely a very manual process. We have 2 funders. It's very resource intensive. The ACBH funding is significantly more qualitative. They like to see patient stories and testimonials. So it's a bit of a different reporting process than what our managed care plan likes to see. Reporting timelines can be challenging to manage too. We report quarterly for the county and monthly for the alliance. So we're always managing those cadences. And also There are national guidelines for inpatient follow-up rates with primary care physicians, but there aren't similar goals for behavioral health follow-up. So we have tried to really work with the county to come up with benchmarks that make sense so we could track progress. Because right now we mostly just look at relative improvement. So we're working with them on how do we really define success for this expansion. And my last slide here, I think, is just looking ahead. So program improvement. We definitely want to expand the program and look at additional funding sources. We'd love to hire more staff. I think I saw a comment in the chat about the CHW benefit, and the program, the way it was set up, was not set up to include CHW support, but now that that is part of the population health management policy guide through CalAIM in their manual, we're exploring, what might it look like for this program to have CHW support. So we'd love to maybe consider that. Standardizing documentation and outreach processes in ways that would really help with reporting to all funders is something that we're looking to do. And continuing to train our nursing staff on psychoeducation, behavioral health. And another thing we're thinking about is, how do we overall standardize our program, because we coordinate it at the network level, but it's pretty decentralized. Every nurse has their own workflow, their own way of following up on patients, and we believe that that's really important because they know their patient populations best. But as we manage multiple funding sources and potentially more, if we continue to expand, we're trying to balance some of that decentralized model that we like with the need to standardize a little bit more to make reporting easier and more streamlined. So yeah, those are our thoughts on braiding.
Awesome. Well, thank you so much, Holly, Kush, Darlene, and Virginia, for giving us an overview of your respective organization and detailing how you're braiding in different kinds of Medi-Cal funds. We will now turn to the Q&A portion of our webinar. Thank you to everyone who has submitted questions. We've received many great questions during the panel discussion and throughout our registration process. We've tried to incorporate some of your questions that came in through the registration process in our content for the panelists. And for the questions coming in now, our panelists have addressed some of them, and we will try to address as many questions as we can during the allotted time we have left. So to our audience, apologies in advance if we do not get to all of your questions. So right now I'm going to ask our panelists to come on camera for us, and I'm going to direct a few questions to you all. Questions that came in the chat, a few have talked about how can we ensure that existing grant funders won't reduce existing grant awards because of the availability of this new funding, or there are concerns that your existing funding sources might reduce their funding because of this new funding. So I'll ask this, this question will be to both organizations. And Darlene, Virginia, I'll ask you this question first, and then you can pass it over to Kush and Holly to answer that same question.
Great, thanks. Virginia, do you want to talk a little again about why it's so important to keep the services and the funding separate?
I mean, absolutely. There was a question, several questions in the Q&A kind of about how that breaks down, and it's critical that documentation, I guess, is what's so critical. Yeah, and Darlene, can speak to how locally there's significant pressure and some really high expectations about this CalAIM funding being the be all and end all, and what that realistically looks like.
There really is, and as some other funding sources are terminating, we're hearing from city and state officials that their thought is that this CalAIM program is going to pick up those services that are no longer going to be funded through other opportunities. Here, at least at our CalAIM House Partnership, that's not the case. What the CalAIM program does is offer different supportive services. Not, we don't supplant. Again, it doesn't offer those other services that funding is going away for. And so trying to help funders understand that they're two different roles, two different sets of responsibilities, two different sets of duties, and that it's not reasonable to expect that this program, new as it is, and even long term, is going to be able to offer the case management or the housing support services that other funding sources do offer currently. And so helping our long-term funders, city, state, federal programs understand this is going to be a huge lift for all of us, I think. This isn't nirvana. This is adding to what we're already doing.
Thank you. And Hallie and Krish, I'll turn it over to you to answer the same question.
It's definitely a challenge. I think that I think Hallie might have mentioned this already, but like our funding from Alameda Alliance is sort of given to us on a yearly basis, and then Alameda County Behavioral Health has sort of done a contract for 4 years. So our funding is sort of a little bit always in flux and sort of like trying to like prove the worth of the program. I mean, I don't think I kind of like I feel like I have said this so much, but like care transitions and good care transitions for our patients is really important for their quality of life. Like the more you're in the hospital, the more debilitated you are when you come out, the more likely you are to go back to the hospital. So I think we keep emphasizing that. And then we have, kind of tried to like make it very clear that the behavioral health portion of this is an expansion. It's not, that we were sort of like already like I'm sure some of our nurses were providing some of these services, but they weren't like we weren't getting money for it or paying for it or getting support for it. So it's an expansion on the program, and I think we kind of have to keep saying that, like all of these things need more funding. They need to be more standardized, and the more funding we get, the better able we will be to provide that support. So yeah, thoughts.
Yeah. I'll just add, I think just being very clear about the goals from each funder, like what are we really trying to do with your funds and how is that different from our other funders' funds? And each of our funders is aware that they are partially funding this program. So it is really helpful for us to be transparent to say, we receive most of our funds from our managed care plan, and they know that the county is supplementing for behavioral health, and ACBH knows about our most of our funds coming from Alameda Alliance. So I think just being transparent and making sure you're having those ongoing conversations with the funders about how you're using the funds would help to avoid, one of those funders potentially pulling back at some point.
Well, thank you so much. And this next question I will direct to Virginia and Darlene. I've had the pleasure of talking to you both previously for the brief that we had recently published, and you noted there was a specific service that you chose not to offer to address the risk of supplantation. Can you talk more about the decision process around that and how you came to that conclusion?
Sure, I can take this. So we get funded through other sources to provide housing navigation and housing support to help people to move from being homeless to being housed. Under the CalAIM program, housing navigation is a service that can be offered, and we're not doing it through CalAIM because we're getting funded to do that through a different funding source. Virginia, do you have something to add there?
Right, the housing deposits specifically are part of other funding sources. So the housing deposits piece of it is something that we just say, you know what, if somebody we're working with needs help with a housing deposit, they're referred to their case manager, and that case manager will go through the other funding source for that.
Well, thank you. And also, while I have you, the next set of questions is really around the client experience. And when the question is around, does the client experience become disjointed, and or how are what's their experience like, especially with the division between the different teams? Do they feel like they're being passed around, and does it feel seamless, or does it feel disjointed because different staff are funded by different funding streams?
So I think first and foremost, you know, I've said it so often, but communication, communication, communication with this, you know, and so regular team meetings, you know, you have to plan as an organization to set aside time for that care coordination within the different programs of the organization. And Arcata House does that and sets aside the time so that all the teams can get together and kind of regroup about who's doing what and which person being served or people being served are rising to the top with critical needs or emergency kind of concerns, and then you know we disperse the duties, you know, according to which program can provide what support, and it's just regular communication. And we have seen that provides a significant benefit to the people we serve. Like some really great stories can come of that with, you know, somebody who's being served by our ECM team has diabetes and had multiple surgeries with amputations because, you know, left with an unstable life, they couldn't stably provide for their medical needs. And you know, being stabilized, having another layer of care and support, now they're on the path to appropriately healing. And so that kind of that progression had been interrupted, and thankfully they're healing. Yeah, and Darlene tells a wonderful story of somebody who had accessed ER services and the criminal justice system so many times within a year, like hundreds of times within a year, before they were stably housed. So the wraparound kind of team approach to supporting the people served by Arcata House can be very significantly positive for them.
I think one of the other lessons we really learned, thank you, Virginia, is that how do we support staff to really engage? And so now every week our supervisors meet from all departments to talk about who's doing what and how we're helping each person. But we also made a major change environmentally. So our staff are all in the same physical location. So if one of Virginia's team has a question about a person, they just walk, 20 steps away and they're talking to the case manager or they're talking to the housing support specialist. And it has really made a very big difference.
That's so wonderful. Thank you for sharing that patient experience and story. Now I'll turn some questions over to you, Kush and Hallie. There are specific questions around the inclusion of ECM services and our community support services with your CTRN program. So are your CTRN staff billing for ECM services, or are they providing community support services at all? So just a clarity for our audience around those additional services.
No, our CTRNs are non-billing. They basically serve as like kind of intermediaries to provide referrals to ECM if they feel it's indicated, referrals to complex case management, and community supports if they're aware of it. So that's the other thing. Like I think it's like something that isn't always like well known and the medical like medical space where like the CTRNs spend a lot of their time, like, you know, these are the services that are available, they would be super helpful. So we've tried to like bring in Alameda Alliance to do presentations on, well, these are the community supports that are available. And I think we need to maybe do a better job of like doing that more frequently so that they can become more familiar. I think this year our focus has sort of been on them becoming like more familiar with the behavioral health services at their clinic. So, you know, like some of our nurses were like, oh yeah, you know, like we have a behavioral health care coordinator right across the hallway, but we haven't spoken to each other in like a couple of years because it just feels like, you know, our worlds don't overlap. And so we're trying to create more overlap there. I think like, you know, medical care is siloed. So we're trying to break down the silos a little bit, but obviously I think everyone here will know that that takes a lot of time and changes in workflows and behaviors. So.
Thank you. Anything to add, Hallie?
No, I think Kush said it. It's a work in progress for sure. Like we were saying, the program was initially created as, you know, like a temporary medical case management and follow-up. And now as we move towards this more whole person care, holistic follow-up approach, it's just taking time for our nursing staff to feel more comfortable asking those questions with an initial follow-up call that normally a behavioral health care coordinator manages. So I think bridging that gap and building that connection with behavioral health will only help us do that.
Well, looking at the time, I unfortunately have to wrap up the Q&A portion of our webinar. Thank you for our panelists, and thank you to the audience for your thoughtful questions. We just so much appreciate you taking your time to join us for the webinar today. And on a closing note, we've recently published an accompanying resource titled Braiding Medicaid Funds to Support Person-Centered Care, Lessons from Medi-Cal, providing a summary of our learnings on different braiding approaches. Our two organizational speakers are part of this profiles in this brief, as well as an additional organization, Path San Diego. So please download our resource and let us know. We love to hear from you. This is still a new approach that organizations are working on. And so please do share with us how you're braiding and connect with me. Okay. And lastly, next slide, please be sure to visit our website for resources and subscribe for our email updates, and please complete our survey. Just again, a big thank you to our wonderful panelists for all that you do for folks in California and the time you're spending to share your organizational experience to our national audience. We so appreciate all that you do, and just thank you so much. And thank you to our wonderful audience. We look forward to hearing from you, and have a wonderful day. Bye.